to you all. Thank you for inviting me to speak to you today. So as Barry's outlined, we're going to just a little bit of an overview perhaps of the population of people with intellectual disability and a consideration perhaps of their universal palliative care needs, but focusing on their particular palliative care needs. Great, brilliant, thank you very much. Okay, so just to orientate ourselves with a definition, when we're talking about people with intellectual disability, there can be some varying definitions and inclusion criteria across different jurisdictions, but it would be generally accepted that intellectual disability is present when the following criteria are met. And that is an element of impaired intelligence, a significantly reduced ability to understand new or complex information and to learn and apply new skills. And then importantly, looking then at the area of adaptive skills or adaptive functioning, a significantly reduced ability to cope independently expressed in conceptual, social and practical adaptive skills. And for the purpose of intellectual disability, differing obviously from acquired cognitive impairment in later life, the onset of the intellectual disability should be before the age of 18 years, and it should have a lasting effect on development throughout the life course. So although we talk about a definition and a population of people with intellectual disability, of course we always have to remember the fact that a population is made up of very disparate individuals within that. One of the domains, I suppose, that is of importance is the degree of intellectual disability in terms of impairment of cognition. And IQ is one measure of intellectual ability, and you can see the different categories or groupings of mild, moderate, severe and profound learning disability there. But very importantly, one needs to consider the experiences that people with intellectual disability may have, their ability to engage in life experiences, the wider community, the environment in which they have been raised and which continue to live, and that's particularly important when we consider the strong history of institutionalization of people with intellectual disabilities. And then of course one's own individual personality and ability to engage in day-to-day activities. And at present, as we'll see, we have had a big shift away from institutional care into care in the community. So the majority of people now with intellectual disability would either live at home or in the family home or in community services, although a significant proportion of people do live in residential care settings, and a proportion continue to live in what might be regarded as the older historic institutionalized type care, such as psychiatric hospitals. So the National Intellectual Disability Database is really the source of an awful lot of our information about demographic and population trends, and also service provision. And Ireland is very well, I suppose, provided for by the National Intellectual Disability Database, a little bit analogous, I suppose, to the Irish Cancer Registry, which we'd be very familiar with. So the NIDD is held by the Health Research Board and collects the data on behalf of the Department of Health. And the NIDD, although it is a very comprehensive database, shouldn't be regarded as solely for the purposes of, say, epidemiology in terms of calculations, because participation in the NIDD is voluntary, and it tends to be for those people who are in receipt of specialist ID services across the country. So it's a set of information that outlines the specialised health services currently used or thought to be needed in the future by people with intellectual disability, and it's been in collection since 1995, and its primary purpose is to inform both regional and national planning of services by allowing the health service providers and the Department of Health from a policy perspective to understand trends in demographics, what the current service use is and what the future service need is. And really all of the data is collected with reference to these three main questions. So what is the demographic profile of people with ID in the Republic of Ireland? What are their ages, gender, level of ID, and how have these changed over time? How many people are receiving specialised services, and what services do they receive? And they go into quite an amount of detail as about residential daycare and so on. And how many people are waiting for specialised health services? And this is a question that's becoming increasingly important as demographic pressures are leading to constraints on service provision. What services are they waiting for, and when in the next 5 years would one anticipate greater needs for those services? So the NIDD produces a report every year that's published on the Health Research Board website, very easily accessible. And this would be one of the infographics that would have been produced in 2016 to give us a little bit of an overview. So you can see there that they have records for over 28,000 people with intellectual disability in Ireland. And generally speaking, the population of people with ID across European countries is anywhere between 1 to 3% of the general population. And when records began, it was only 38% of people, so that was in 1995, that actually were aged 35 years or older. So there has been a significant increase in life expectancy, with now 49% aged 35 years or older. But you can see that's still a life expectancy that is falling short of the general population. The importance of these kind of figures, and something for us to bear in mind, is that because people are living longer, for those people who are in residential care services, they're occupying those spaces for longer periods of time. And therefore there's less, I suppose, throughput to allow new entrants come into services as required. And so that's really becoming an acute pressure point in the system. There's a preponderance of males on the register as opposed to females, and you'll see the breakdown of levels of disability between mild, moderate at 41%, severe 14%, and then profound. And then a number that are not verified, and that would usually be the children that are on the Intellectual Disability database who have as yet haven't gone through the full assessment for a final determination of level of disability. The row or the column on the left-hand side, as I am looking at it on the screen, are the services that are provided at the moment. So just to give you an idea of that population of 28,000 people, 7,600 are in receipt of full-time residential services, but the remainder are either receiving part-time services or not needing some services at all. But the vast majority are accessing some level of service, with 27,000 having at least one day programme and having a reasonable degree having a multidisciplinary support. But considering the complexity of need of a lot of these people, it's interesting that a number of people are not receiving full multidisciplinary care, that it might be single discipline as such. And you'll see the numbers of respite nights really being quite low in proportion of the overall there at 4,300. And then I'll leave you to read at your own time, but you'll see on the right-hand column really what it's pointing out is the growing demand for services that is going to be facing us in the coming years. So before we look specifically at palliative care needs of people with ID, just to give, I suppose, a little bit of an overview of the health status of people with ID and the reasons, I suppose, the general context in which we need to consider when we're providing palliative care. Now, it's an obvious statement, but one that is worth repeating because of the fact that for so long we've had such a medicalised model of disability where, I suppose disability is seen as an illness or an impairment in and of itself. And there's been a failure to consider, I suppose, the social determinants of disability, which are in essence the barriers that society places on people with intellectual disability reaching the full potential of themselves as individual human beings. But very clearly, intellectual disability in itself is not an illness. However, we do know that people with intellectual disability tend to have poorer health than their non-disabled peers. This is both true in Ireland and across the world. And to a certain degree, the difference in health status that people experience are to a degree avoidable, because they are the consequences of either suboptimal healthcare provision or general healthcare services that aren't tailored to meet the needs of people with intellectual disability, and therefore they receive poorer outcomes than the general population. Recognising this, you'll have all heard very much in the media over a number of years now at this stage, the importance of the UN Convention on Rights of People with Disabilities, which looks towards changing the societal perspective in order to make a society one that is more accessible to people with intellectual disabilities. And Ireland remains the only country in Europe that has not yet ratified the Convention on Rights of People with Intellectual Disabilities. So the bottom line is that people with ID do experience a shorter life expectancy. Some of the more recent data is beginning to demonstrate that people with mild intellectual disability are now approaching similar lifespans to the general population, but the all-cause mortality of people with moderate to severe learning disabilities remains 3 times higher than the general population. And although it can be difficult in terms of the methodology to access subjective ratings of quality of life, a number of studies would show that people with intellectual disabilities and a variety of functionings would tend to experience poorer quality of life than peers from the general population. Thinking specifically about some of the manifestations that might impact on the way that we provide care, well, the proportion of people with intellectual disability who die from cancer is actually lower than the general population. These are UK figures, but would be similar in terms of Ireland. And I suppose to a certain degree that's because cancer is a disease of older age, and so people with intellectual disability were not necessarily living long enough to develop cancer in the same way. But it probably is also, to a certain degree, a later, I suppose, suboptimal diagnosis of cancer as well. And some of the lifestyle features such as smoking, people with intellectual disability are less likely than the general population. The one cancer I suppose that we particularly should be thinking about is that people with ID do have higher rates of GI cancer, and part that can be attributed to the high rates of Helicobacter, particularly for gastric cancer, because of the high rates of institutionalization in the past. People with intellectual disability due to Down syndrome can experience higher rates of leukemia in the pediatric population. But I suppose the take-home message with the cancer piece is that the incidence and pattern of cancer is changing as we're beginning to see some of those demographic changes in the population. We're not quite sure whether the overall prevalence of cardiovascular disease is different to the general population. It is still an important cause of death at 14 to 20%, and particularly we need to think about the fact that people with Down syndrome will often have high incidences of congenital heart disease, which will be problems that often last into adulthood. So in terms of cardiovascular disease, I suppose the mitigating facts are perhaps less smoking, but then perhaps obesity and lack of exercise in terms of how that plays out. Respiratory disease really is the one that potentially we see an awful lot of in terms of presentations to palliative care. And it is the leading cause of death, with figures up to 50% as such, and the rates really are much higher than in the comparable general population. And there's a variety of reasons for the development of respiratory disease, including physical associations with intellectual disability, suboptimal mobility, and very importantly swallowing problems, which then will lead to aspiration pneumonias and so on. Another important one for us to think about is the prevalence of dementia being much higher, and particularly affecting the population of people with Down syndrome. And then more generally, the prevalence rate of epilepsy is higher than the general population, and seizures are often difficult to control. One we don't think about, but important just in terms of comorbidity, higher rates of injuries and falls. And in some studies it's been very significant in terms of that. As we'd understand, high increased rates of visual, hearing impairments, diabetes, hypothyroidism, one to think about, increased rates of osteoporosis, but when you combine that with the falls risk and so on, you can get quite a significant morbidity then in terms of fractures. Overall, poorer oral health, both gum and dentition. As I've mentioned, in terms of the respiratory disease, 8% of adults known to ID services are affected by dysphagia, and it's estimated that about 20% of patients or people receiving residential care will require assistance with feeding. So it's a very much an important one. High rates of gastroesophageal reflux disease, perhaps in part related to the Helicobacter as well. Constipation, not to forget. Women tend to have earlier menopause, which can increase risks around osteoporosis and dementia. And then one for us to remember, pain, both acute and chronic pain. And some studies actually report rates of up to 70% of people with intellectual disability experiencing chronic pain due to their associated physical impairments. In terms of mental health, the figures are quite variable due to methodological issues across the various studies, but I suppose some of the particular conditions one might think about would be anxiety, depression and schizophrenia, and the prevalence rates are high, anywhere between 20 to 70%. And one to think about, 10 to 15% of individuals have challenging behaviours. The importance for that is that oftentimes when somebody has then a physical illness, particularly a serious or life-limiting illness, the problem of diagnostic overshadowing can occur, whereby people with intellectual disability who have communication impairments may not be able to express the physical distress that they are feeling, and they'll manifest it by changes in their behaviour. And particularly in those people who will have a preceding diagnosis of challenging behaviours, that behavioural disturbance will be just put down to the challenging behaviour, and therefore there'll be a failure to investigate and to manage for the underlying physical cause. So just an important one for us to tease out. I've mentioned impairments of communication, but it really is key, so it's worth spending a little bit of time on it. Actually, in looking at the overall population of people with ID, over 50% of people may experience some impairment of communication, and it can be due to the variety of reasons. It can be due to the issues of the cognitive impairment, the intellectual functioning, so therefore the conceptualization of speech and the expression of speech. It can be due to the hearing impairment. It can be due to difficulties with language. People with intellectual disability will often have smaller receptive and expressive vocabularies and difficulty in understanding abstract concepts, which again is of direct importance when you're considering issues of loss, grief, death, dying, understanding death and dying in peers of people with ID. Speech disorders can be present, and there can just be more generalized social interaction challenges, which then will manifest in terms of communication distress. So it's very clear throughout the general literature that there are health inequalities that extend over general healthcare provision and mental health care provision, and these inequalities are thought also to extend to palliative care, but unfortunately our evidence base is relatively small. Irena Tuffrey-Wynn would have done most of the systematic literature review work. The most recent literature review from herself, I think, is 2008, although they're looking to update that material now. And what she would have found is that the studies that would have been done in palliative care are often case series or even case studies, and as such we don't have the same quality data, but what the studies that we do have tends to show that people with intellectual disabilities tend to have fewer referrals to specialist palliative care, and those referrals will often be made with quite advanced disease. And the fewer referrals to palliative care may in part have been due to the historic cancer versus non-cancer debate, but it can also be due to the fact of, I suppose, there can be, siloing of healthcare systems where intellectual disability services are seen in one part of the service provision, and they can have had experiences where it has been very difficult for them to access mainstream hospital services, and there therefore can be a distrust or a difficulty, I suppose, an anticipation of difficulty in terms of accessing specialist palliative care. And often if people aren't fully worked up or investigated, then therefore the usual patterns of referral, whether that be from oncology or heart failure and so on, may not be activated, and intellectual disability services simply may not have familiarity with palliative care services to know how to refer. So I'm just going to really talk about, I suppose, some of the work that I would have carried out with colleagues in Ireland 9 years ago at this stage, and that we are now beginning to review. Just to give you a little bit of those particular, I suppose, focuses of need of people with intellectual disability. So what we did was we carried out a corporate assessment of palliative care need in one HSE area in Ireland. And as you'll know, there is kind of three types of needs assessment, whether that be an epidemiological needs assessment, comparative needs assessment, and corporate needs assessment. Epidemiological needs assessment is when you have very strong epidemiological data that you can look at and compare and look at through the disease cycle in terms of assessment of need. A comparative needs assessment is where you have one area of excellence or benchmarking best practice that you then compare the needs of the group that you're looking at against that benchmark. And a corporate assessment of palliative care need is one that's quite commonly carried out in palliative care, I suppose, as well, is where you go out to the stakeholders and you ask them about their experiences of care provision and their views about what are the strengths and the deficits. So that's the type of assessment that we did. So it was, I suppose, a two-part kind of a study, a dual methodology. We did a broad overview, a questionnaire first, which we distributed to 389 staff in both 3 intellectual disability services in that one region and the specialist palliative care service. And the 3 intellectual disability services were good representation of national services, because one was a service that had been set up by parents, very much community-based, strong ethos of care from that perspective. The second was the more traditional religious order provision of services, ones that would have grown up in the 18 and 1900s and carried on with, so perhaps a greater tradition of residential care provision. And the third was the psychiatric model of intellectual disability care provision. So again, long-term residential care on the grounds of a psychiatric hospital. So a good spread. And then the specialist palliative care service would have been typical of our national services. So we actually had a huge response rate, which was indicative of the interest that people had in the subject. And we also then carried out 16 focus groups across the various intellectual disability and palliative care settings, and 91 staff members participated in that, with a breakdown of 2/3 coming from the ID services and 1/3 from specialist palliative care. And obviously for the questionnaire, which was mainly quantitative, we used statistical, mainly descriptive statistical techniques, and we used framework analysis, a form of content analysis for the analysis of the focus group data. So just giving an overview of the responses to the questionnaire, as might not be surprising, but actually is of big relevance when you're looking at how do you devise a model of care for people with intellectual disability. The area was regarded as hugely important by staff. Everybody commented that they thought it was an important area of service provision, but experience was low. Even in the intellectual disability services, because of, I suppose, the disparate nature of service provision across communities, small group homes, care at home, people, although people would have cared for aging people, the numbers of people that would have died each year were relatively low. One person maybe each year or every couple of years. So the question, have you cared for somebody with intellectual disability towards the end of life in the last year, was answered that the majority of people, 60%, over 60% of ID staff and over 40% of palliative care staff actually hadn't come in contact with a person with intellectual disability. And when they had come in contact with it, the numbers really were 1 and 2. And the numbers that were kind of 4 and 5 were those units where perhaps they were specialising in dementia care, or some of the ID services had set up kind of almost like palliative care support bed environments, and they would have transferred patients there. So that's a real challenge for service provision. How do you develop and maintain the skills of people if you're caring for small numbers of people each year? And what was very interesting was that the organisational memory seemed to be lost, so that if you did build up a little bit of experience in one area, and say your adjoining house kind of 2 miles down the road then experienced somebody needing to care for somebody towards the end of life, there was no transfer of knowledge. You know, the staff in that house were separate to the staff in that house. There was no going down or sharing or anything else like that. So that was an important piece. And did this impact on care? Well, it really did, because the confidence then that staff had was moderate. I suppose we did a Likert scale, 0 to 10, in terms of 0, no confidence at all, 10, very confidence. And we looked at the group of intellectual disability staff, and we looked at the group of palliative care staff, and we asked them to rate their confidence in managing issues of pain and symptom control and communication for people with a life-limiting illness for the intellectual disability staff compared to their usual population of people that they were caring for. And for palliative care staff, we asked them to compare it from a person with ID versus the general population. And what you'll see is that from a pain and symptom control and a communication point of view, their confidence in pain and symptom control, as might be expected, is a little bit lower than communication, bearing in mind that a lot of ID staff are social care staff as opposed to healthcare staff. But their pain and symptom control, they give us 6.8 on a Likert scale, 68 if you're looking at it 0 to 100. And their communication, reasonably confident at 76. But then when you're looking after somebody with a life-limiting illness, their confidence drops down to 60 and 58. And if you look at palliative care staff, their confidence, as you might expect, or we'd be glad to hear, confidence in providing to the general population was high, very high, recognising specialist staff, 86.85 there. But when you looked after people with intellectual disability, it dropped right down to moderate levels. And interestingly, pain and symptom control going all the way down to 54. And communication dropping all the way down to 51 as well. So, for a specialist staff, that's a low level of confidence. And we then looked at the groups. So if you had had experience in caring for somebody, did it impact on your confidence going forward? And it did have an impact. So ID staff with experience would certainly rated themselves more highly than those without. And palliative care staff, it did also impact, but not to quite the same degree there, as you'll see with the figures. So the key finding really from the qualitative work that echoed those quantitative findings was that care was both different and difficult. And really, I suppose that what summed up what an awful lot of people were saying was this quotation was, you do the best you can within the situation and you hope that it's appropriate to the situation. So a real sense of just kind of flying somewhat in the dark and hoping that good intentions and that kind of support of people around will be enough to get people through. So aggregating all of the focus group data, what we found was that very clearly a number of particular palliative care needs came out through the interviews. And the areas here are outlined here, and the ones that I have bolded are the ones that I'm just going to talk about in slightly more detail because we don't have enough time to go through them all today. But particular challenges around the issue of communication, okay, that we're very skilled and used to engaging with people from the general population around issues of life, loss, illness, death, and so on. But there are particular challenges in engaging in our normal communication style with people with intellectual disability. The establishment of a therapeutic relationship is very different. It would appear from the perspective of the specialist palliative care staff when engaging with people with intellectual disabilities. I'm going to talk about that a little bit, and that does have an impact then on outcomes. Pain and symptom management is more challenging for a variety of reasons, because people have high levels of chronic pain, because of the communication impairments, and then in terms of how one assesses and manages, and how does one then assess the response to analgesics and different interventions. The presence of comorbid physical disabilities, sensory disabilities, and challenging behaviours. So, for example, if somebody's being cared for in an inpatient unit, the intellectual disability staff would have been quite concerned that the palliative care staff wouldn't have had specialist expertise to be able to care for those areas that they were very experienced with. And perhaps there was less confidence, certainly from the part of the specialist palliative care staff, about managing issues like challenging behaviour. Continuity of place in carers is of particular importance. Very much would echo, I would think, the experiences that we would have of other vulnerable groups where continuity of care becomes particularly important. Understanding of illness, death and dying, unsurprisingly a challenging area, because as we've said, the impact on both intellectual but also sometimes emotional functioning can mean that one's understanding and conceptualization about these issues is different, and that can lead to increased risks of complicated grief in the peers of people with intellectual disability. Decision making was challenging, mainly because of issues of capacity, and then the lack of legislation around that would have made it a difficult area to operate in. And then from the perspective of the intellectual disability staff, people often had very long and close relationships with the people that they were caring for, and they were being asked to make decisions in the role of a health or social care professional, but often they were approaching them from the perspective of somebody with a close relationship. So they also they almost had a kind of a schizophrenic role where they were expected to function as a staff member, but they were processing emotions as though they were a family member. And there was very poor recognition of this across the healthcare system, and not always a recognition of it on the part of the specialist palliative care staff. And people would describe very graphically the idea of being in a multidisciplinary team meeting held in the intellectual disability staffs, and maybe, you know, the medical physician or the consultant psychiatrist might talk about the fact that somebody had now a life-limiting condition, and now what were their support needs, and what would we talk about, do not attempt resuscitation. And the intellectual disability staff would have described finding this, you know, a very, very difficult experience. So if you think about the way that we break bad news and we engage in decision making with families and friends, you know, that opportunity was not afforded to them. Suddenly they, you know, they were doing their regular MDT, and then out of the blue they would almost have said, we were talking about do not attempt resuscitation. And because the intellectual disability staff had less experience in dealing with the ethical issues around end of life, they found it more difficult to reason and work their way through. Some of the areas that we would assume healthcare professionals would be very confident and competent in, withdrawing, withholding care, were not approached with the same evidence base or knowledge base as maybe in the main healthcare system, which one can understand when you consider the purpose and focus of intellectual disability service and disability services in general is quality of life and maximising quality and functional ability. So that's hardwired into the DNA. So the idea of supporting people with declining function is something that is almost counterintuitive. And then the importance of recognising emotional and psychosocial needs of family, which I think we would do within specialist palliative care, but often the relationships of family to people with intellectual disability can be quite complex. And particularly there is a cohort of people, perhaps because of the historic nature of care provision, where people with intellectual disability went into long-term and residential care settings, often geographically quite different and quite removed to where the family home was. You might have a history of perhaps more fractured family relationships, and then as a person becomes more unwell, family members re-establishing links with people who have been in residential care, but then the complexities from a staff point of view that they have been the main carers over the course of the life, and now they see family members coming in, and where do they manage that in the dynamic. Going to talk about fellow service users because it's an interesting one from our perspective as what's the unit of care. We talk about family being the unit of care, but there certainly seem to be a blindness on our perspective that actually the peers of people with intellectual disability could be considered to be the family. And also then, as you'll have inferred from the decisions about the emotional links, the emotional impact on staff and the considerable impact that it did have on people from working in ID services. So talking about those communication contexts, most participants across the intellectual disability and specialist palliative care services found it difficult to provide information to people with ID about their illness, and both staff groups rarely engaged in open communication. The exceptions were those members in specialist palliative care who either had a family member with intellectual disability or who had previously worked in ID services and had transferred into specialist palliative care. Those were the only people that really felt more confident and open to the idea of engaging in open communication. And then intellectual disability services, the exception was a dementia care unit. And it wasn't entirely clear why this unit in the overall organisational culture would have adopted a different approach, but they had a very proactive approach to communication. But across the ID services, by and large, people didn't openly communicate. And they acknowledged it. It wasn't that people were against the idea of communicating per se. They didn't necessarily think it was a wrong thing to do, but they felt that they lacked confidence and they were very concerned that they would do harm. And there was a sense that if they did harm, they would be judged. And I suppose social care staff were concerned that if they did something wrong, that the healthcare staff would find that problematic. So, as one person said here, but when it comes to speaking about death to them, we're not familiar with it. We're familiar with nursing them and everything else, but to sit down and discuss with them, even when they want to talk about it, I even find it hard. And that was from a respondent who was actually working in a palliative care support bed environment, so they were perhaps more familiar with talking, but even they found it difficult. So, as I've mentioned, the majority of participants didn't think that it was wrong, but they were concerned that their lack of skill and experience would cause harm. So really people were operating in kind of suspicious awareness environments with people to mild to moderate intellectual disability and closed awareness environments with people with severe ID. So obviously a closed awareness environment is where the person themselves doesn't appear to have insight, and that would be understandable perhaps with those people with severe ID in terms of their ability to understand and process what's going on, although some of the evidence did show that people had a biological awareness of illness even with a severe and a profound disability. And in a mild to moderate intellectual disability context, the person actually was aware that something was going on, and would have begun to ask questions, so would have had a suspicion, but in a suspicion awareness environment, those openings would have been closed down by staff looking after them. So to give an example of that, this respondent in one of the focus groups said, I'm thinking of one person in particular now, and she was very aware. She was crying. She didn't know what it was, but she just felt it in herself that there was something seriously wrong, and asked that, and has said that, am I very sick? Has said that, am I very sick? So she was really reflective. She was like, it was that piece. You can almost hear the echo of how often the person is asking, the way that she's saying that. So in terms of then the interviewer, and how would you respond to that? Well, you wouldn't really say that you aren't, but you'd say that you're going to get better. We're going to get everything done for you. We'll see what happens. So very much from a place of, good intention from the heart, that emotional response, but not having the skills to be able to go into that area. And another example, we found some days now when we had to leave her in her bed, say she wasn't really able to get up, she was scared in the dormitory on her own, she'd start to cry. She prefers to be out with everybody. We kind of, even when we're giving her tablets, we'd say, this is for your sore arm, this is for your sore leg, and that kind of thing. She'd feel better. And that's the kind of level, well, deal with it. I think to a certain extent, yes, she would understand, but I think it wouldn't be good for her, because I think maybe it would scare her, and because she has the understanding of it. So, as I said, one unit in all of the services, the intellectual disability services, had a very different approach, and they were very clear about that. So we, from the very beginning, we kind of developed that relationship with patients and families, because we know what's going to come. We try to prepare for it. And that might have been some of the reasoning behind it in the dementia unit. They did see it as an advanced stage, and that death and dying was something that was approaching. But why they would do it, and other units that equally were looking after high dependency patients didn't see that in the same way, we're not entirely sure. But they would see the minute the person was transferred from a lower dependency into their unit, they start working towards it actively. We work with them from the word go. And they had some examples then of when they had inherited, if you like, collusion or closed communication or suspicious awareness context, and that they were unable to break that down because of very strong influence from the key workers that had still been involved from the community. And we asked, how did you find that worked out? And the word was, it was a disaster. So they had very positive experience of communicating and engaging at the level of the person. I'm not saying having full and frank discussions, but engaging and involving peers, and they've had positive experiences of that. What added to the complexity was the role of relatives, and it could affect the dynamic in a variety of ways. In some instances, relatives acted as gatekeepers, or perhaps the perception of the staff was that they were gatekeepers, and really all they were doing was encircling around and providing love. But because of the fact of the continuous presence, staff found it hard to communicate with her. Everything went through the family, And the interesting thing, although we're used to families, I suppose, acting in a protective and a supportive manner, and we manage that with the normal population, and we find ways of developing that communication and relationship, specialist palliative care services seem to have a much more passive role, to perhaps be more intimidated by the fact that the others were viewed as the expert carers, and they were reluctant to challenge the expertise of either the family or the other staff. So here a specialist palliative care staff is saying, well, it's a learning disability, but you can't really tell until you interact with him, I think. So a mild level of disability. Like, if he was sitting there, you really wouldn't know. And the other person who knew the patient as well was agreeing, he has no obvious learning disability, no obvious learning disability, but I'd say he's always had it all his life, but he was always protective, and I know that his sibling was always there for him. And you said in some ways it would be collusion in any other circumstance. Well, it would, yes, because we would speak directly to the patient or ask the patient's advice. But in regards to that patient, we don't really, because we don't know whether he'd be able to understand, which I suppose is kind of presumptuous, really, as they're reflecting on it. So turning then to therapeutic relationships, staff really valued patient-professional relationships highly. So, and that's not uncommon. I suppose specialist palliative care and intellectual disability both are hugely person-centred services. So all really valued that piece around the therapeutic relationship between patient or client and staff. And there was unanimous agreement across all settings that experienced familiar people were the best people to provide care because of their in-depth knowledge of the person. And that in-depth knowledge really enhanced the carer's ability to provide care across all domains, whether that be physical in terms of pain and symptom management, whether it be communication, emotional support, management of ethical issues. That in-depth knowledge was felt to be really, really important. And the factors that were identified as being fundamental to the development of this therapeutic relationship were actually remarkably similar across the different groups. And they fell into three main domains. The first was the idea of trust. You had to build trust. Trust was one of the fundamental things to having a good therapeutic relationship. And the interesting thing that came out was that there's this idea of time-dependent versus swift trust. So specialist palliative care is unusual insofar as we see people and we actually engage and develop relationships with them remarkably quickly. Sometimes it can be over the course of a first consultation that you're having a conversation about things that are very, very profound. And I suppose because it's something that we do so often, it doesn't always perhaps strike us how unusual that might be to other healthcare professionals who come in. And so how do we manage to do that? Well, there's just a concept in one paper of this idea of kind of swift trust. And I suppose we trade on a number of things that allow us get into that relationship that can be very profound very quickly. And some of the things are organisational credibility. So that idea of the ethos, palliative care being associated with a particular kind of care and that going in, that automatically puts one in a place or a position that enables certain things to come up. The second thing being, I suppose, we very quickly, we look at the quick wins, the concrete yields, and we build on those. And we don't even necessarily know that we're doing it, but you deliver good pain and symptom control. Or if somebody has a difficult problem that they can't access a medical card or a practical support, we do and we deal with it. It's partly because obviously it's the need of the person, but actually the small wins build us things that we know then that will allow us engage in a deeper therapeutic way. And I suppose we have that specialist knowledge and expertise, and we have that confidence that comes with that allows people then engage in those areas. But if you think about those kind of three things in terms of organisational credibility, delivering on something that allows you then move into a different area and having an air of knowledge and specialist expertise, none of those things really hold currency if you're a person with intellectual disability. So those key things that we use to develop swift trust aren't there. And even if you were to deliver pain control or something like that, the person with intellectual disability may not linked from an abstract point of view that you're the person that has sorted out the pain. So in terms of trust for people with intellectual disability, it really is time dependent. And all of the intellectual disability with staff would talk about that, building up that relationship often over years. It's a long process for the women to trust you, for the women to want to talk to you or open up to you or anything like that. So that's a challenge for us. How do we develop trust in a time-confined, constrained manner? Continuity being a really important thing as well. I think for people with learning disabilities, for a lot of time, they take a long time to form a relationship with somebody. And then from the specialist palliative care perspective, we've different staff going in. They can't identify with different people all the time. They need familiarity. And again, that's a challenge for us now because we have become less, able to deliver continuity of care for a variety of reasons. But again, I suppose perhaps analogous to some of the paediatric situations insofar as we try, particularly in certain vulnerable groups, to have one key worker and minimise the changeover. But do we recognise people with intellectual disability as perhaps being in that as well? And then this idea of knowing the individual as being so important to the therapeutic relationship. And this person from the ID services was talking about each of us would have a client issue to us, you know what I mean? So you kind of need to know everything you do, even their favourite colours, their whole background and their families. And then the person said, but we nearly need to have to because they don't talk to us. You need to get that bit deeper to really find out what's going on. So to get them more comfortable, you're not just using your own intuition, you're using theirs as well, communicating with them. So also that idea of, really, really knowing somebody to understand. So all this piece around the lack of the therapeutic relationship actually had quite a profound effect on specialist palliative care staff and probably impacted, really was the reason why there was the hesitation and the lack of confidence. As one person would have summarised, I have very little personal experience. I really would rely on the family and the carers. We as the professionals are new on the scene. so we depend on what others would say. And there were impacts of that suboptimal therapeutic relationship, both in our effectiveness of pain and symptom control, in our support and engagement around decision making, very importantly around communication, psychosocial support. And you see there from this quotation, there's an example of somebody that, the specialist palliative care professional really felt that they couldn't engage in communication because the person with intellectual disability wasn't necessarily asking questions. So they felt, oh, well then I won't go in and say something. But that's quite normal for somebody with intellectual disability. They're often not proactive in asking questions. So therefore having an approach, which we would often do, is we'll wait and see what the person asks, may actually be constraining them and not allowing them to engage. And just to bring us back to really that importance of therapeutic relationship, just a quotation from Cicely Saunders, which I think does sum it up. You're missing something, as well as the patient missing something, unless you come not merely in a professional role, but in a role of one human being meeting another. And Michael Carney, as the emphasis on the Aesculapian tradition of healing as opposed to the Hippocratic tradition of cure. And if you think, palliative care is really grounded on that sense of healing rather than cure. And important within that, the caregiver is facilitating healing by providing a secure environment grounded in a sense of connectedness. But if we don't have that connectedness, can we really deliver palliative care? So then just to turn to, I suppose, the importance of considering peers in terms of service provision. I suppose the staff perception of the importance of relationships was clear. Now, a number of people varied as to whether they considered fellow residents to be family or to be friends or not friends. About half of the people would have felt they were family. Others would have kind of said, well, it's a variety of relationships. But no matter what the relationship was, even if you couldn't stand the person, as it was said, it was still a very important relationship when you'd lived with somebody for a number of years. So the impact of a peer's death on the person with intellectual disability was absolutely clear across all levels of disability. And you can see here this lady with moderate to severe disability. There was a lady that had no communication. She was always in a chair. There was a death in that particular bungalow. At some particular stage, either at the removal or before the removal, I was standing between two chairs and she put her hand in mine. Now that spoke volumes to me. And I suppose again, just another quotation, reinforcing the impact of that. So intellectual disability staff were very aware of the impact of deaths on peers, and specialist palliative care staff were aware of it, but didn't necessarily always consider it and didn't always show an awareness of the fact that people with intellectual disability are more likely to experience complicated grief, so actually probably need more support than the general population in terms of proactive preparation. And one quote that would have suggested, I suppose, that indicative of that approach was, I think maybe they forget quicker. It's just that something has happened and that, their grief, I think it might be a little bit different. And that was actually, they were referring to a person with intellectual disability whose mother was dying. And they came in quite differently across the day. Sometimes they'd be very sad, other days they'd be very happy. And it was kind of like, it was put down to the fact that maybe they actually didn't care as much, whereas actually that was the person's way of processing it. And very clearly, all specialist palliative care staff really didn't see peers as part of the family and didn't see it appropriate for them to engage and look out for other peers, perhaps because they were other service users or whatever reason. But in the same way as we would go out and look for vulnerable people in a wider family context, we didn't go looking for people in bungalows. We kind of felt almost, I suppose, that they were the responsibility of the intellectual disability staff. So the involvement of peers and preparation for change really was focused around the time their peer was dying or afterwards, actually. So you'd get very little communication across the course of the illness. Around the time the person was taken to bed and beginning to actively die, there might be some communication, and the majority was after death. And so an example here is you more or less go around it. You wouldn't really discuss it with them. You'd go around it and say that they ate their tea or whatever. You'd put them off the beaten track. So you're confusing people who already have a difficulty understanding the concept. And why wouldn't you discuss it? Well, it's confidentiality, you know. So a variety of different reasons, but a kind of a sense in some ways, which is very paradoxical in terms of talk about normal living arrangements and social networks, and yet we then put people in a box of, oh, you're receiving this service and this is confidential. When people were involved, and there were very positive experiences of people being involved, the experience was universally positive. And there was nearly a winding down process. They were quiet and reverent nearly, and you could nearly say to the clients, or at that time anyways, you know, would you like to spend some time with Beth? And they would go and they'd spend their 10 minutes. And even houses with people with challenging behaviour actually talked about the challenging behaviour sometimes becoming quieter around that time. Not in a romantic or other way, but again that sense of connection and emotional impact perhaps that in all ways needs to be important and to be considered. And what was the impact of excluding people? Well, people who were already challenged in understanding loss, death and dying became particularly confused, and really it was quite remarkable the degree to which houses that had now experience of people developing dementia and dying, the peers became very, very frightened. We're actually beginning to catastrophize and have experiences, I suppose, you know, thinking that perhaps some people were saying losing your mind or dementing was the natural process that happened to everyone, or that if people die, you know, that everybody would die, and people would die quite suddenly, and how would you know whether somebody was unwell? So, as somebody said here, they'd come up with theories that would frighten you. You'd go, God, it's like listening to a child. Like a child would come up with things you wouldn't think of yourself. She's another one. Is it going to be me next? She wasn't sick. You have to be sick before you die, you know. What happened to her? What happened to her? Was she sick? Was she sick? Just trying to make sense of it all. So I suppose in terms of what are the lessons to be taken from all of this, although I suppose spoken about some of the differences today, a key take-home message is that the care of people with intellectual disability does share very many commonalities to the care of the general population. You know, so we need to remember that. But we do need to consider there are some important differences, and I suppose because we're providing specialist services where things are often complex, those differences become more important to us. And just thinking about those kind of, I suppose, experiences across the services, I mean, how well, if we were thinking about our own service today, what do we know about how we provide care to people with intellectual disability? Have we looked at it? Have we assessed it? Do people with intellectual disability in our area have equity of access? So are the access rates for the ID population similar to the general population, or are they less? Do they have equity of outcomes? And that's the important thing. Is their experience of receiving care as good as a person from the general population? And I suppose the follow-on questions from that then are, do we need to adjust our usual model of care provision to ensure high quality care provision? So do we need to think about getting involved earlier? The idea of, say, perhaps if somebody's going through a plateau, a period of maybe disease quiescence, and where normally we would step back and say to people, we'll discharge you, contact us again. Actually, do we need to maintain the relationship? Because there was some indication as well that actually services found it harder to re-engage. And actually, is that longer period of time more important for us to develop that relationship? Do we make it an absolute priority that is the same person going out to see the person with intellectual disability all the time? How do we think about how we're interacting with the caregivers and our communication with them? Are we using them as surrogates, or are we really more using them as partners and bringing our expertise? And do we, you know, what is the support that we provide for peers? Is it our place to do that? If it's not our place, how do we ensure that that care is provided? So just to say, I suppose the EAPC have done some work across the European countries and have developed some consensus norms for people with palliative care, looking at these variety of areas, describing what good care might look like. And so that reference is there for you to look at. And so from our point of view, our next steps really lie with the Intellectual Disability Supplement of TILDA. And we now have a cohort of people who have died over a number of years. And this now will be a nationally representative sample. So we're going to go through a process of interviewing the carers of those decedents and seeing whether those particular palliative care needs that we described in that regional sample are now recognisable across a national sample, example, and because there will be 10 years by the time the period between the two data collections, has service provision developed and changed over that 10-year period? And if it hasn't, that would really challenge us to understand and put some focused work into seeing what we can do. So thank you very much.